Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. On this episode, I will present part 3 of my review of head and neck masses. And in this episode, I will also review some of the anatomical spaces of the neck that are high yield for radiology board exam purposes. Thank you to all of you who have recently written to me. I've had several of my listeners write to me asking advice about your study plans for the ABR core exam, particularly as the exam is now approaching and is only a few months away for many of you. A common thread I have had is, what resources can I recommend that might be helpful for you as you push forward to prepare yourself for the ABR core exam? One resource that I think all of you listeners should be aware of, and if you are currently studying for the ABR core exam in 2021, it might be worth your time to check out a new community on Discord for residents, fellows, and radiology faculty to help R3s and R4s get ready for board exams at a time when people can't get together to study in person. Grace Zhu, a radiology resident at the University of Utah, whose Twitter handle is @TotallySkates, started this new community that currently has over 400 residents engaging on the platform and over 60 radiology faculty who are also on the platform. I myself have been there and have found the content on this Discord site to be useful. So go ahead and check it out and see what you think. I will post the link for this radiology board study site on Discord in the show notes of my podcast. I will also tweet out the link so you can find this by searching my Twitter handle @RadRevPodcast. Thank you to Grace Zhu for making me aware of this opportunity, and I hope this will be helpful for you listeners who are studying for the ABR core exam or other radiology board exams. With that being said, let's get into this episode, part 3 of my review of masses of the head and neck. First question: what are some of the contents of the parotid space? That is parotid with a P. What are some of the contents of the parotid space? The contents of the parotid space include the parotid gland itself, portions of the facial nerve, which runs lateral to the retromandibular vein, and intraparotid lymph nodes. Related question: what are some of the contents of the carotid space? This time C like cat. What are some of the contents of the carotid space? The answer here includes the carotid artery, the jugular vein, cranial nerves 9 through 11, and lymph nodes. Next, what are some of the contents of the masticator space? In the masticator space, we have several muscles, which include the masticator muscle itself, the temporalis muscle, and the medial and lateral pterygoid muscles. Additionally, the mandibular angle and ramus are considered part of the masticator space. We also have the inferior alveolar nerve. Note that the masticator space extends through the length of the temporalis muscle upwards, extending over the lateral aspect of the skull, and this space traversing the length of the temporalis muscle is a potential space, which creates a potential avenue of spread of infection or malignancy. Next, what is the most common cause of a masticator space mass? The answer here is somewhat of a trick question, but an abscess from odontogenic infection would be the most common cause of a masticator space mass. I know that is not a cancer or a solid mass. Nonetheless, if you see a mass lesion in the masticator space, you may want to exclude an abscess from an odontogenic infection before you consider other entities, at least on the board exams. Next, infections in the masticator space may classically, for board exam purposes, spread to which other structures? The answer is that infections in the masticator space may classically spread into the cavernous sinus and or the orbital apex via the pterygopalatine fossa. So the pterygopalatine fossa is an important avenue of spread of infection from the masticator space into either or both of the cavernous sinus or orbital apex. Next, what types of sarcoma can classically involve the temporomandibular joint? Sarcomas that can classically involve the temporomandibular joint include rhabdomyosarcomas and chondrosarcomas. Next, what is the retropharyngeal space, which is also sometimes called the, quote, danger space? The retropharyngeal or danger space is a potential space that is seen at the midline of the neck behind the alar fascia that extends all the way from the base of the skull to approximately the T3 level. Next question. What is the significance of the retropharyngeal/danger space? The retropharyngeal danger space is a potential space that can facilitate spread of infection or malignancy from the neck, importantly, into the mediastinum. So a classic scenario is spread of a tonsillar abscess and infection all the way inferiorly through the retropharyngeal space into the mediastinum. So I have mentioned two potential spaces, one being under the temporalis muscle in the masticator space extending over the lateral skull, the other within the retropharyngeal space, which extends from midline from the base of the skull all the way down into the thorax at the T3 level. Keep those in mind for board exam purposes. Next, what are differential considerations if you see necrotic lateral retropharyngeal nodes? Top considerations for necrotic lateral retropharyngeal nodes include squamous cell carcinoma metastases and papillary thyroid cancer nodal metastases. Enlarged lateral retropharyngeal nodes without necrosis raises the likelihood of lymphoma. So again, if you see the necrotic node, you're thinking squamous cell carcinoma or papillary thyroid cancer metastases. If the nodes are simply enlarged but not necrotic, that raises the likelihood of lymphoma. Next, what is Griesel syndrome? That is spelled Grisel. What is Griesel syndrome? Griesel syndrome occurs when a retropharyngeal abscess causes torticollis and subluxation of the atlantoaxial joint, and this is most commonly seen in children. As a reminder, torticollis is when you have a process that causes asymmetric contracture of the neck musculature, causing the neck and head to bend to the side. Griesel syndrome occurs when a retropharyngeal abscess results in torticollis and subluxation of the atlantoaxial joint. If a question presents you with fever and new torticollis, you need to consider the potential of Griesel syndrome and query whether a retropharyngeal abscess is present. Next, what is Lemire syndrome? Lemire syndrome is jugular vein thrombosis and septic emboli from a neck and or upper respiratory tract infection. Recent surgery of the head and neck would be common in a question stem asking about Lemire syndrome, And importantly, Lemire syndrome with jugular vein thrombosis and septic emboli from a head and neck source has a classic association with Fusobacterium necrophorum. Again, that is Fusobacterium necrophorum, and the association with Lemire syndrome. Next, what are some of the contents of the parapharyngeal space? The parapharyngeal space contains branches of the trigeminal nerve, as well as the pterygoid veins and fat. That leads us into the next question. What is the significance on board exams of the parapharyngeal space? Classic for board exams is the significance of displacement of the parapharyngeal space, because how the parapharyngeal space is displaced can guide you to the source of a mass or infection in terms of what anatomic location a mass or infection may be in. Let's dive into that further. Describe the significance of parapharyngeal space displacement in terms of the surrounding anatomic compartments. If the parapharyngeal space is medially displaced, that would suggest that there is a parotid space process. So again, medial displacement of the parapharyngeal space suggests a parotid space process. Anterior displacement of the parapharyngeal space suggests what process? The answer here is carotid space, carotid with a C. So anterior displacement of the parapharyngeal space, there may be a carotid space process, whether mass or infection. Next, what about posteromedial displacement of the parapharyngeal space? The answer here is a masticator space process. And finally, what about lateral displacement of the parapharyngeal space? The answer here is superficial mucosal space process. Another way of remembering this is that there are 4 spaces that surround the parapharyngeal space. The masticator space is anterior and therefore would cause posterior displacement, or sometimes you'll see posteromedial displacement of the parapharyngeal space. The parotid space is lateral. Therefore, this could displace the parapharyngeal space medial if there is a mass lesion. The carotid space is posterior and therefore would displace the parapharyngeal space anteriorly with a mass lesion. And finally, the superficial mucosal space is medial, and if a mass lesion were present there, it would displace the parapharyngeal space laterally. Take a few minutes to review this. You can download the free study guide on my website covering head and neck cancers to get this in written form. I do think this is worth your time knowing for ABR core exam purposes, and it's one of those things that you just simply need to memorize. And searching images online of the various spaces in cross-sectional anatomy could also be greatly beneficial here. Next, what anatomic structure separates level 1A from level 1B nodes? For head and neck cancer evaluation, knowing the spaces of the neck and knowing the cervical chain lymph node anatomy is of importance, so we are reviewing them here. What anatomic structure separates level 1A from level 1B nodes? The answer is the anterior belly of the digastric muscle. Next, what anatomic structure separates level 1B nodes from level 2A nodes? The answer here is the stylohyoid muscle. Next, what anatomic structure separates level 2A from level 2B nodes? The answer here is the internal jugular vein. Next question. What is the anatomic structure that constitutes the vertical border of level 2 and level 3 lymph nodes? The answer I am looking for is the lower aspect of the hyoid bone, HYOID, hyoid bone, is the anatomic structure that separates level 2 from level 3 nodes in the vertical plane? Next question, what is the anatomic structure that constitutes the vertical border of level 3 and level 4 nodes? The answer here is the lower aspect of the cricoid. So again, the hyoid separates level 2 from 3 nodes, and the cricoid separates level 3 from 4 nodes in the vertical plane. Last question for cervical lymph nodes. Level 5 lymph nodes are defined as being posterior to what structure? The answer here is that level 5 lymph nodes are defined as being posterior to the sternocleidomastoid muscle. The level 5 cervical region does have a fairly lengthy vertical extent through the neck, but it is posterior to the sternocleidomastoid muscle. Next, which cancer is classic for a fossa of Rosenmuller mass in a young adult person, perhaps of Asian descent? The answer I am looking for is nasopharyngeal squamous cell carcinoma. Note that invasion of the parapharyngeal space fat is a very bad prognostic sign. The most common location of nasopharyngeal squamous cell carcinoma is the fossa of Rosenmuller, and the earliest sign of this entity is often effacement of the fat within the fossa of Rosenmuller. Next question, where is the fossa of Rosenmuller? The answer here is that the fossa of Rosenmuller is posterior and superior to the eustachian tube opening and is located posterior to the torus tubarius. Nasopharyngeal squamous cell carcinoma can present with a unilateral mastoid effusion. You should particularly consider nasopharyngeal squamous cell carcinoma if you see a unilateral mastoid effusion with enlarged retropharyngeal lymph nodes. Next, what are the 3 types of laryngeal squamous cell carcinoma by location? A secondary question is which of these location-based types of laryngeal squamous cell carcinoma has the best prognosis? In terms of laryngeal squamous cell carcinoma, you can have supraglottic, glottic, and infraglottic involvement, that is glottic, glottic. So supraglottic laryngeal squamous cell carcinoma, glottic, or infraglottic laryngeal squamous cell carcinoma. The second question I asked is which of these typically has the best prognosis? The answer here is that glottic laryngeal squamous cell carcinoma typically would have the better prognosis because it becomes symptomatic earlier, and therefore you would detect this at a lower, earlier stage than other subtypes that may be clinically silent. In particular, subglottic laryngeal squamous cell carcinoma is often clinically silent and unfortunately often presents at higher stage with local lymphadenopathy. If you see transglottic squamous cell carcinoma that is extending throughout the supraglottic, glottic, and or infraglottic regions, that obviously means that the tumor is more aggressive and is a bad sign. Final question for this episode. What is the most accurate sign for cricoid invasion on imaging? The answer I am looking for is that if you see tumor on both sides of the cricoid, you can suspect that there is cricoid invasion. The trick here is that the cricoid can have some normal irregularity, so an irregular appearance of the cricoid alone does not confirm invasion, but if you see tumor that extends on both sides of the cricoid, you can probably assume that cricoid invasion is present. And this is important because why? Cricoid invasion on imaging is important to point out because invasion of the cricoid is a key differentiator between whether the vocal cords may be spared at surgery, and invasion means they typically cannot be spared. Let's leave it here for now. I've already presented 3 episodes on head and neck masses. I hope these have been helpful for you. I am fully aware that these are not comprehensive reviews, and we have not even touched things like orbital or thyroid masses. I do plan to get to those on future episodes, but I do think it is time to move on to a different topic for the next episode. I will make a study guide for these 3 episodes on head and neck cancers available for free download on my website, theradiologyreview.com. Also, check the show notes or my feed on Twitter at RadRevPodcast for the link to the Discord ABR board study community. I think this could really be helpful for many of you and is an opportunity for you to connect with radiology residents and faculty members from across the country who are all working with a shared goal of ABR core exam preparation. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.